of the 8th National Conference of Howrah Diabetes Study Society. And the topic for the last session is diabetes and sepsis, a deadly duo. And to speak on this particular topic, I would like to invite Dr. Susruta Bandyopadhyay, who is a consultant in critical care medicine. And to chair this particular session, I would like to invite 3 consultant critical care medicine physicians, Dr. Anirban Korma, Dr. Pradeep Pal, and Dr. Arijit Raha. I welcome speakers, sir, and I welcome chairpersons to kindly be on stage. And the last session of today's scientific fiesta goes as diabetes and sepsis, a deadly duo.
Presentations. The chair is by Sepsis and Diabetes Tolerant. Good evening, and I thank the organizers for this honor of inviting me. And actually, I've been here around. I've never heard of this organization before. I heard that it is there for 7 years. Anyway, I see it's a dedicated and a committed organization, and it was interesting meeting you all. So, my practice is as an intensivist. We started intensive care way back in '95. Working in intensive care. At that point of time, intensive care or critical care had not been developed as a specialty. It was just nascent. Right now we have moved away quite a bit. One of the main diseases what we treat in critical care is sepsis. This is again, when we started, people were not aware of it. If we could have told someone that you are having a septic shock or sepsis or you are dying of sepsis, even in the early 2000s, it was difficult to convince a person that they could die of infection and die of sepsis. But after that, it has become popular, and people, I think, are quite aware of there is a thing called a sepsis. So my topic today is very specific, that is sepsis and diabetes mellitus. Both are serious diseases. One is a chronic disease which may worsen the other outcome of other acute illnesses, and other is, of course, an acute illness. Sepsis or septicemia is a life-threatening illness caused by body's response to an infection. There are 3 stages of sepsis, as we know: sepsis, severe sepsis, and septic shock. This is slightly older, our older understanding of the disease. I'll discuss how it is so. And as soon as there is sepsis, there would be organ failure. That makes just any infection, even with a very high WBC count or a very high CRP, may not be sepsis unless there are signs of organ failure. And if there are multiple organ failure, then we call it as a severe sepsis. And if the patient becomes hemodynamically unstable and requires support in spite of adequate fluid resuscitation, we call it septic shock. This was our first understanding. Actually, this was the second understanding, sepsis 2. This is, you can see that at that time people were understanding it this way, that there is a thing called a systemic inflammatory response. Body in response to something develops this sort of complications, like there might be a temperature of more than 38 or hypothermia less than 36, heart rate more than 90, respiratory rate more than 20, or there is respiratory alkalosis, PCO2 less than 32, and WBC count could be 12,000 or more, or less than 4,000 with, and there might be more immature cells. So this they found could be associated with a severe infection. It could be also associated with trauma, sometimes with some other illnesses, say like pancreatitis, where initially at least there are no bacterial infections. And you could see there are overlaps. There is an infection, and some of the infections would go into sepsis with organ failure, and some of them will become a severe sepsis. So again, I've told you, so this were our thing, that's systemic inflammatory response syndrome, then sepsis, severe sepsis, septicemic shock, and multi-organ dysfunction. But after that, people, they argued that whenever we are taking, what do you mean by severe sepsis? All sepsis are severe. Basically, sepsis means an infection which has caused an organ failure, and potentially all these patients are very serious patients, and they may suddenly turn bad and they die. So they did away with a thing called a severe sepsis. All sepsis inherently are severe. So we have got a sepsis 3 definition, which means sepsis is equal to a suspected infection with an infection indicator. This is the weakest link. Basically, till now, when it is a florid infection or quite advanced infection, all of us can pick up infections very easily. When it is early, it is difficult. Sometimes there is no definite test to say whether this patient has got a bacterial infection or not. So still now, there are multiple markers, multiple criteria, scores, but you cannot definitely say that whether this patient at a certain point of time is having an infection or not having an infection, and is early in the disease. This is our 500 years old knowledge. Basically, during the Renaissance, a non-medical man, Italian Machiavelli, he said that his idea was toxic fever, which basically would translate into sepsis. He said that once it is florid, everybody can pick it up, but then it is too late, and in the early stages, it is very difficult to pick up. I mean, very, very wise words, and we also know right now that initially when the patient comes, often in our say OPD or sometimes we cannot predict that this patient is going to go into sepsis or just developing sepsis. Initially when the patient comes in the ICU with some distress, sometimes it is quite difficult to pick up whether the patient has got an infection or non-infective. So this is the weakest link, and once we have proven that this is due to an infection, then we go this scores. One is a SOFA score, sequential organ function assessment score, or there is a Q-SOFA score, which is a quick SOFA score. I won't go into the details of the scores. I think you are all using these scores. All of you are working in ICUs. SOFA is a detailed score of several organ systems, of respiratory, of cardiac, of renal, and of hematological. So there is an elaborate scoring system, and you can see if there is an increase in SOFA score by 2, you know the patient is progressing into a sepsis. And there is an easier thing. There is a Q-SOFA which can be applied in bedside, which depends only on hypotension, tachypnea, and mental confusional state or mental sensorial disturbances. 3 of this, if you get 2 of this, then you can call this patient sepsis. It makes the diagnosis very easy at the bedside. Of course, cannot be specific, because these 3 things can be found in many other conditions. Some patients might be inherently having these things. A patient, already a demented patient, would be having confusional states, or a patient, elderly patient, even with heart failure, may have confusional states. So that does not exactly, but then it makes you aware that this could be sepsis. On top of that, if you can show there is an infection, then you call it a sepsis. Sepsis again can derange the body's homeostasis in several ways, from DIC, cardiopulmonary pathology, disturbance of red and white cell rheology, that is the flow through the vessels, viscosity alteration, vasoplegia, where the patient cannot maintain the blood pressure because of the loss of inherent muscle tones of the both arteries and veins, altered microvascular circulation, opening of AV shunts, which shunts away the blood away from the vital organs, decreased dead cell permeability, increased microvascular permeability, edema formation, intravascular pooling, congestion, hemorrhage, endothelial activation, and redistribution of organ blood flow. So these are basically, a sort of continuum. That not that you get a specific thing for a specific disease, but this some of these are involved in most of the sepsis patient, and they may come in together, or initially one point might be taking precedence over the others. And ultimate result is that disturbed microcirculation in severe sepsis. So these also remains an point of interest for the people who try to understand the physiology of sepsis. They go on trying to pick up derangements in microcirculation. So we have got this extensive visualization of the tongue, subglottic area, and you try to find out the microvascular flow pattern changes, but they have not gained that clinical importance yet. And this is another problem of sepsis. Basically, whenever we have, I won't go into the details, I'll just show you that there is basically, when there is an initial sepsis, there is an initial early response of inflammatory mediators like IL-1, IL-6, IL-8, etc., and the activation of complement coagulation and phagocytes. After that, there is a cellular immune response when the B cells are activated. Neutrophils and myeloid-derived suppressor cells are also activated. And then comes the late humoral response when this B cell starts producing the IgG and IgM. So all these things that together they cause the fever, they help in us the body fight against the bacteria or the invading pathogen, but it also causes the inflammatory responses like fever, tachycardia, tachypnea, hypotension, sometimes hypoxemia, even severe shock. All these are because of this. Simultaneously, or maybe slightly late, there is also a thing called, this part is what was our understanding of SARS, systemic inflammatory response syndrome. Simultaneously, we also have got counter-regulatory syndrome, where this inflammation is countered. The body also wants to control the inflammation, because we know that if this inflammation goes out of hand, the body would be suffering just because of that. So this counter-regulatory mechanism also starts. This is called CARS, something like SARS, and there is a decrease of HLA-DR expression, T-cell exhaustion, and apoptosis of immune cells. So sometimes these are well balanced. There is an initial inflammation response which helps us fight the infection, and there is a simultaneously CARS which curbs down the excessive inflammation, and after sometimes the body goes and attains this homeostasis and is stabilized. In some cases, the SARS may go out of hand and the body may die early out of severe organ failure, severe shock, whatever it is. And sometimes this CARS may go out of hand, and what happens, these patients, they go on after that going into immune suppression, they go on getting infection after infection, and they ultimately die of that. So basically, a sepsis patient coming out of sepsis and going into recurrent sepsis may not be just that your hospital is to be blamed. It can be just the body's immune response is going to do too much of CARS. Now we have got a basic idea of our first part, that is the sepsis. Now we understand a little bit of diabetes. Diabetes, all of you, your association is diabetes association, so no use trying to tell you much about diabetes. I just tell you that this is a common disease. Basically, it is more than 77 million people affected in India, and expected to rise over 134 million. So it's a common problem right now in India. So many patients who would be having sepsis will also have a simultaneous diabetes. There might be people who would be diagnosed diabetes earlier, and then you know that the patient is diabetic and going in for sepsis. There might be some people who actually develops a glucose intolerance transient during the sepsis, who are not diabetics, and some people who are not previously diagnosed as diabetic, they have come with the sepsis, and then you find that patient could have been diabetes previously. This third group, they fare the worst. That is, they are diabetic, they are not diagnosed and they are not controlled, and now they have come directly with a septic shock. That is, these people, they fare the worst. So how diabetes basically, sort of influences our innate immunity. So again, lots of physiology, but we'll go by the bottom lines. Basically, both obesity and diabetes, they affect our immunity negatively. Remember, it is obesity. Basically, there have been papers to show that slightly overweight people not amounting to obesity, they might be handling sepsis better than people who are, with ideal body weight. So little bit of fat might be protective. Also, just one study, but then it was a good study which showed that. But obese people, definitely they fare worse. And we knew that during our COVID period, these obese people were the first who went very bad with the COVID. Actually, they tolerated the infection very badly. So both obesity, I not discuss the obesity part, I'm just discussing the type 2 diabetes. They influence the neutrophils, and that is the alternate first line of defense by decreasing migration, phagocytosis, production of this reactive oxygen specimens. So neutrophils, they become less efficient, they don't go to the proper places, and they cannot kill the bacteria as good as they are supposed to do. Then also this M1 macrophages are increased, which again abnormal inflammatory response. These are ineffective macrophages which do not control the infection well. Next, about the natural killer cells, abnormal phenotypes, functional defects with decreased degranulation, and they are also abnormal inflammatory response, and abnormal T cell response, that is when the late sort of immunity comes, cellular immunity comes, these are also affected in diabetes. So with that, you can see where both of them, they join hands to disrupt our immunity. So here is chronic hyperglycemia, which increases reactive oxygen species production and oxidative stress. Diabetes-induced inflammation, low-grade inflammation remains in the body, and increased pro-inflammatory cytokines. So the surge might be actually stretched in diabetes, and these patients may go into severe shock initially. And diabetes-induced immunosuppression, it comes later, that endothelial and neutrophil dysfunction, fluctuation of low inflammatory cytokines, impairment of antioxidant machinery, humoral cellular immunological disorder. So these people are also enabled to handle later, say, secondary infections. And this way, we are seeing what sepsis is doing to them, monocyte activation, and then release of pro-inflammatory cytokines, and sepsis-induced inflammation and activation of the immune response. So this will activate the coagulation process, which will increase the tissue factor, and together with diabetes, they will worsen the endothelial dysfunction, tissue injury, and organ dysfunction. Also, release of arachidonic acid mechanisms and leukocyte adhesion, complement activation, and neutrophil activation, all this will also add to endothelial dysfunction. Together, they will join hand and make the patient, handle the sepsis worse and the outcome worse. So, not only these patients are liable to be worse in the initial presentation, they also have problem in handling post-sepsis secondary infections, or when there is that excessive curve I showed you at that point of time. This is the basic idea of sepsis management: hemodynamic management, modulation of the host response, infection management. We won't go into the details, you know the ideas. So basically, we knew that diabetes is possibly not good for sepsis. But the first solid evidence came, this was a paper in 2001 by one lady, this is called Vandenberg, who showed in a surgical ICU, if you intensely control glucose, in the sense that the blood sugar level was kept between 80 to 110, and then that was a significant improvement in mortality in septic patients. So the intensive care group had less days of ventilatory support, less renal impairment, less need for renal replacement therapy, less bloodstream infection, less need for antibiotics, less blood transfusion. One single study, and it was so impressive that initially that time we were forming the first surviving sepsis guidelines. That was the first awareness, 2000, around 2000. It was instantly included in that, and it was said that you maintain the blood sugar between 80 to 110. So this is difficult in a very ill patients. When you try to maintain such a strict blood sugar control, these patients are either you need a lot of insulin, etc., and these patients are very liable to go into a thing called a hypoglycemia. After some years, this was another German study, which was basically, it was a multi-theme study. They were studying the insulin therapy, they were studying the starch infusion in septic shock, etc. So there they showed that conventional versus intensive insulin therapy, conventional is when the target was between 180 to 200, and intensive insulin was again 180 to 110. There was more incidence of hypoglycemia, but no improvement in mortality with strict blood sugar control. So this is one which makes the people skeptical about Vandenberg's trial. I'll go into the details of the trials in the next 1 or 2 slides after this. But last trial, which was 2009, this was a nice sugar study. This was a government-sponsored large trial and parallel non-controlled randomized trial in 42 centers, and 6,000 medical and surgical patients were included. And it was randomized to tight control, blood groups 88 to 108, and conventional group is less than 180, which was reasonable. And primary endpoint was death from any cause in 90 days and serious adverse event, blood glucose value less than 40. So that was the trial, and it showed definitely there was increased mortality with intensive blood sugar control. You can see that this is the first line, and 90-day mortality was statistical p-value was significant, and intensive insulin had 27% mortality, and the conventional blood glucose had 24.9% mortality. And at day 28 also it was 22 by 20.8, it was not very significant, but long-term mortality was definitely worse in the intensive care group. And it was, if you go through the details, whether the patient died in ICU or elsewhere in the hospital, or had cardiovascular distributive shock or other cardiovascular causes, all cases, the intensive glucose control group fared worse. And this was the last nail in the coffin of this Vandenberg's concept. And right now our directive is that we try to maintain the blood sugar less than 180, but we do not want a too tight a control. 140 to 180 is our basically target. So these are the trials. This was Vandenberg's first trial, which made that first trial I showed you. That was a surgical ICU. Vandenberg after that repeated the same trial in a medical ICU, where she could not show that mortality benefit with intensive insulin control. Although she showed that the people, they stayed in ICU less number of days and could be weaned off ventilator earlier, but mortality there was no difference. And this was the Buchholz trial, German trial, which showed that intensive insulin care did not give any, or diabetes control did not give any mortality benefit, but caused more hypoglycemia. This was another glucontrol trial, which showed that higher rate of hypoglycemia in patients with intense control, no difference in mortality. And last is the nice sugar, which definitely showed that increased mortality with intensive insulin therapy. So right now our understanding is that this Dr. Vandenberg is still convinced that her report was, the idea was right. She feels that the only thing is that our problem is with hypoglycemia. So she is right now researching with those newer computer-mediated continuous blood sugar monitoring, and the computer decides the insulin to be given. This sort of machines, which will, minute to minute, it will check the blood sugar and adjust the insulin accordingly. And she hopes that this will someday show that intense blood sugar control is definitely better than an average blood sugar control. And there have been other types of trials too, which showed, this is of course a Chinese trial, they did not show any worse outcome with the diabetes in sepsis patients. So basically the debate, although we have got a strong leaning towards that we need to control diabetes in sepsis, we need to control it modestly, not too tightly, but definitely the debate is not settled. As I've told you again, that this sepsis is a multifactorial thing. Just trying to connect the outcome of sepsis with only diabetes might be difficult. Thank you. If anyone would like to comment about anything, you're welcome.
So that was a very nice presentation, sir. I have one small question. We use insulin for the diabetics, and when they're septic also we use insulin. So does insulin have an immunomodulatory effect, and does that help during sepsis?
Cell by cell, it is difficult to say. I think that is the domain of the basically research people who would be showing that what is happening to cell by cell. But basically what we are concerned about is how it is affecting the outcome. So what we measure is that our mortality, we ventilator free days, renal replacement therapy, ICU length of stay. So these are the basic parameters which have been shown. Definitely control of blood sugar with insulin improves most of these parameters. But as I've shown, possibly we should not overdo things. If we try to achieve too much with the insulin, then we'll be having more hypoglycemia and more, worse outcomes.
Sir, suppose a patient was well controlled on just 1 or 2 oral hypoglycemic agents and passed on to severe sepsis, had shock, and we automatically went on to give insulin. How quickly we can afford that patient to come back and have oral hypoglycemic agents? Is there a rule, or it is absolutely tailor-made?
There are 2 issues. One is that the 2 questions which are basically which are asked. One is that initially most of these patients who are in severe shock would be on a insulin infusion. When do we get the patient of insulin infusion to a regular sort of insulin? And once that regular sort of insulin comes, when we can possibly think of taking off the insulin and putting the patient to oral hypoglycemics, if possible. So first question is basically when the patient is not very hemodynamically unstable, and the patient does not have, the sepsis is reasonably controlled. The most important thing is that if the patient is still on a large dose of vasopressors, it's better to continue. Even if the patient is otherwise stable, it is better to continue insulin infusion. Once the patient is off that, you can always change to basal bolus insulin therapy. And the rule of thumb is that when the total insulin requirement is less than 30 units per day, you can try to take the patient off the insulin to oral hypoglycemics. Though I don't think there is a strong medical evidence to, this is just what we practice.
Sir, how often should we check the blood sugar, and what should be the modality? Like capillary blood sugar is better, or arterial, or what we are saying, a loop feedback mechanism is coming up right now is better?
No, basically when you are giving an insulin infusion, it is RD. We cannot do anything other than sometimes people because of, price control, etc., or poor manning, they go for 2 hourly. But that is maximum you can go. If a patient is on infusion, you cannot do less than that. Capillary blood sugar is easier to do. If you can afford, you can have got an arterial line, you can draw a blood and give that, but then that makes the patient handling the arterial line too many times. It adds to the hazards. I don't think that is very good.
So, any patient admitted in the ICU, we want a good glycemic control 140 to 180. How often should we test the blood sugar? Like 4th hourly,
So
6th hourly?
once you are telling the patient it's off infusion,
Yes.
yeah, then actually normally what do? If you are giving a basal bolus, the patient is thrice is the usual
Right.
blood sugar. In an ICU patient, if you feel the patient has got other risk of hypoglycemia, you can make it maybe 4 times or 5 times, sometimes late, early in the morning. So when there is a chance of hypoglycemia, you can check once.
Great. Thank you, sir. Thank you so much.
Role of heparin, hydrocortisone and vitamin C in sepsis.
Basically, there are 2 different questions. One is vitamin C. Vitamin C, there was a lot of interest created with Marek's paper which showed a definite mortality. After that, several trials has been done, but last trial, if you see, there is called a LOVIT trial, L-O-V-I-T. It came, I think, 2 years ago. 2021 or 22 it came. So LOVIT has shown definitely that vitamin C in a randomized controlled trial increases mortality. So no question of vitamin C right now. Hydrocortisone definitely in septic shock, there has been enough trials which showed that hydrocortisone is a standard recommendation. You use hydrocortisone when the patient is requiring a reasonable number of vasopressors. For 5 days you can use hydrocortisone, total 200 to 300 milligrams per day, either as an intermittent bolus or as a continuous thing. And there was a concept of HAT, that you have got this hydrocortisone with ascorbic acid, vitamin C and thiamine. I think with that vitamin C showing the increased mortality, we cannot use HAT anymore.
And heparin, what about heparin?
Heparin. Heparin is a standard. Basically, heparin, what are the indications? Basically, if there is you will have to give, most of the patient will require a DVD prophylaxis, whatever you give. Next thing is that if you feel that the patient is going into a DIC, so in that case, in early cases when there is when you get the thing that there is a lot of coagulation, microcoagulation happening, there is a question of low dose heparin. But the problem is that most of the DIC patients, when we diagnose and you diagnose, they are already in florid hemorrhage. That's when we become aware. I don't know, I don't have any protocol to say how do we pick up very early DICs when the patient is having that procoagulant state. So we don't have the luxury to use heparin in these patients anymore when we find the patients. And other there might be some specific indications like having an acute coronary syndrome, pulmonary embolism. So there, what do you give?
Routinely you don't use heparin.
Routinely we give for DVT prophylaxis.
DVT prophylaxis.
Yeah.
Okay. Thank you.
Thank you.
Thank you, Speaker, sir. Thank you, Chairperson. Sir, I request you to kindly be on stage for the felicitation. I request Chairpersons to kindly felicitate Dr. Susruta Bandyopadhyay. I request Dr. M.L. Bhansali and Dr. Guru Prasad Bhattacharya to felicitate our chairpersons. Thank you, Chairpersons. Thank you, Speaker, sir, for this wonderful session. With this, we come to the end of the first day of the scientific fiesta of the National Conference of Howrah Town Diabetes Study Society. So with this, I bid good night to each one of you. I thank all the founder members, the patrons, all the delegates, chief guests who joined us today. And with full zeal, we'll be back tomorrow morning for the second day of the scientific session. Thanking you all. Good night.
That is 50 gram of carbohydrate from the another category of carbohydrate food. Am I clear? Are you clear?
Not really. No, so,
So area under the curve, suppose after 50 gram of glucose ingestions, blood glucose rises from the baseline, blood glucose rises 100. And after taking white bread, which contains 50 gram of carbohydrate, blood glucose rises, say for example, 80 milligram. So area under the curve, this difference or this area under the curve is actually the measure of the glycemic index. It is measured in percentage. So 80% is the glycemic index of the white bread. So am I right? Am I clear? So then you can similarly, you can get the glycemic index of any carbohydrate food. Say for rice, if the polished rice increases the postprandial glucose, polished rice which contains 50 gram of carbohydrate, the amount of rice which contains the 50 gram of carbohydrate, which rises the blood glucose after a period of 2 hours, say for example 70, then its glycemic index is 70. So this glycemic index of watermelon is very high, but the glycemic load is low because 80% or 90% of the constituent is of water. So if you take 100 gram of watermelon, actually you are taking 10 or 20 gram of watermelon. So though the glycemic index is very high, but the glycemic index is low, but the glycemic index is low, glycemic load is low, but the glycemic index is high. On the other hand, the chocolate, which has very high fat content, so that it lowers down its glycemic index. So the chocolate is the answer.
okay, thank you. And just one point that as we all know that protein is good and it should be taken, in greater quantity. But according to NIN Hyderabad, initially the recommendation was 1 gram per kg per day, but they have reduced it to 0.83 grams.
Yes.
So what is the purpose? Why?
The recommendation is, I think the range is 0.8 to 1 gram per kg per day. Not a clear cut 0.8 gram per kg per day. The idea recommendation is 0.8 to 1.
Yes,
the range.
Yes, previously it was 1 and now
If
it
there
has
is
been
no
0.83
0.8.
recently.
I do not know the reason why they have reduced this
thank you.
cutoff. Lemon juice.
Lemon juice number 1, number 2 guava, number 3 cucumber.
Number 3 is the
Cucumber. Shosha. Cucumber.
cucumber contains lots of fibers and the glycemic index that's why is very low. Usually we should not consider it as a fruit. We should consider it in salads, actually in vegetables or salads. And regarding the fruit juice, as I have said that fruit juice it does not contain fibers. Rather whole fruit contains fibers. So it lowers the glycemic index, but on the other hand, the fruit juice, which is processed, which is made outside, that increases the glycemic index because of the lack of fibers and other constituents. So that causes the sharp rise of postprandial blood glucose. Emni lebu. Achha. I think there should not be any concern, the lemon juice.
Okay, thank.
Don't drink fruits, eat fruits.
Okay, it's a very. Do you have any questions?
These days, lot of studies are coming that showing that consumption of both the fermented and non-fermented dairy products is associated with long-term cardiovascular morbidity and mortality, and also the incidences of cancer. So, lot of controversial studies are now coming. So, what is your take on that?
Fermented products actually contains lots of beneficial bacteria, so that can improve the gut microbiota status. So rather that can reset the gut symbiosis. So that I have shown one of the slides and I have touched upon those aspects little bit. That how fiber improves the glycemic control and it has got other benefits like inflammations. So that resets the gut dysbiosis. It causes the symbiosis of the gut microbiota as the fermented products contains lots of favorable bacteria which are important for the prevention of the inflammation and it increases the small chain fatty acids in the colon, in the large intestine. So that is beneficial actually. That prevents meta-inflammation, that prevents inflammation in the intestinal wall.
Okay, thank you. It's a very nice and interesting session, but because of time constraint, we cannot allow any more questions. So we are concluding the session now. Thank you all.
Thank you, Speaker. Thank you, Chairperson. It's time to felicitate our Speaker. I would like to request our Chairperson to please felicitate him. And now I would like to request Dr. B.P. Pandey to please felicitate one of our Chairperson. And then I would like to request Dr. Sanjay Shah to please felicitate another Chairperson.